Welcome to the Nurses and Hypochondriacs podcast, Mel Cortez.
Hey, thank you so much for being here. I'm really excited. I love the brand that you've built and just your commitment to providing really quality content for the industry is really beneficial. So thank you for
Well,
everything you're
thank
doing.
you so much. I love what you're doing as well. I think it's amazing.
Thank
So
you.
tell us
Yeah.
about yourself. Who is
So
Mel
I am
Cortez?
Mel. I am a registered nurse. I got my Bachelor's of Science in nursing. I never wanted to be a nurse. My dad was a executive, and he said, "Look, here's Forbes magazine's top up and coming 10 careers. This is the one you're gonna pick. One of these if you want to be have help for with school." And so I said, "Okay, I guess I like biology." So I decided to be a nurse. I never really even knew another nurse growing up. A lot of people have these really great, like compelling illness stories. I really don't. So I ended
I
up
don't either.
yeah, I ended up like barely passing nursing school. Like I was just a terrible test taker, I was
Me too.
distracted.
Me too.
And so I like my nursing professors nowadays would be like, "You got to be kidding me. Mel's doing what?" Like that's not the same person we knew. But I ended up falling in love with critical care. And obviously in order to be a really efficient critical care nurse in Baltimore, that's like, really well trained, classic, we have tremendous amount of experience and great thought leadership up there with Hopkins and University of Maryland. I was fortunate to work at shock trauma and be able to get a really rounded perspective. I was a travel nurse for 15 years and did the whole COVID ICU thing as well, and managed and did home health, hospice, anything that we could imagine. And my parents were really frustrated, right? Because they're like, "Oh my God, she just cannot keep a job. Like, why don't you just get somewhere, work, get your 401k, like get your pension?" And I realized it was because I was supposed to be a consultant, right? I was supposed to be a thought leader in the space because every place I went, I just seemed to care a lot more than everybody else. And I was like, "But you guys could be so good. I mean, you could be so good. Look at this potential. Look at the opportunities that you have and the problems that we can solve." And as a bedside nurse, that can be really frustrating. So I always tell people, like, if you feel like you're getting frustrated with the lack of the ability to cause systems change, figure out what the thing you can do in your sphere is, get really good at that thing, and then start telling people about it. And that's kind of really where I got my start, right? Was just that thought leadership and posting on LinkedIn, and then really having a student mindset and um, trying to develop a way that I could be impactful in the industry. If there were things that I wanted to see to be done differently, then what could I do as a nurse to do that? And that's kind of how I got into the business world.
I love that. I mean, I could relate to you as well. I had so many jobs, the same thing. Like, I love doing registry because it
Mhm.
gave me so much freedom to do other
Right,
stuff.
right.
And my parents said the same thing to me. Like,
What's
get
wrong with
benefits,
you?
stay with one place. What's wrong with you? And I even remember I worked at Children's Hospital as well for like 6 years, but I worked like per diem, like full time
Uh-huh.
per diem, and I was also teaching. And it gave my parents street cred. They're like, "Oh," like, they were telling everybody where I worked, and I'm just like, and when I quit, they're like, "What are we gonna tell people now?"
Right? My parents were the same way. They were just like, "You're doing what now? We don't understand. Like, we have no
Yeah,
idea."
yeah.
I'm like, "Mom, I met with the Institute of Homeland Security." And she's like, "Oh, that sounds great. I think are things going, but how are you going to pay your bills?"
Right.
I'm like, "Well,
Well, it'll
that's
happen. You're like, "I'm in the 4th dimension, and it'll
I'm
get
like,
to
this
the
is
3rd
different. We're
dimension."
different up here, but okay, don't worry about it, Mom."
Exactly, exactly. I love it, and it's so true. I spoke at an alumni panel for students a couple weeks ago at UCLA, and that was one
Mhm.
of the things. There were two other nurses who were also entrepreneurs on that panel. It almost seemed like everybody was an entrepreneur on that panel, which was great.
Yeah.
Because you really want to get out of your box and figure out what you can do. I know there's a couple of nurses trying to make nursing STEM, like,
Yes.
to get it into, like, noticed
Science,
by STEM,
technology. Yeah.
which I think it yes, I mean, nurses are innovators.
Yeah,
It's like
Rebecca
we're
Logan, Marion Larry. Yeah. And I think
yeah,
I think that's one of the things, like, networking and relationship building, that's what nurses are great at,
Yeah, for
and that's where
sure.
I've seen a tremendous amount of success over, in this healthcare security industry. When I started my consulting company 4 years ago, I really wanted to create solutions to some of healthcare's most complex problems. I was like, look, if I can do it at the bedside or as a nurse manager or as a, weekend house supervising nurse, like what is wrong with the system itself that can't figure this out? And I think it just is about being creative and about having some thought leadership in the area and
Yeah,
being like, look, let's try something innovative. Let's try something different, because when you're solving problems, you're not really consulting. A consultant is somebody who innovates and creates a future solution that will help with profitability, legacy, and prevention, right? And those are the three things. And right now, going with what Florence Nightingale said 200 years ago, nothing can be done in the presence of, fear. You really can't do anything when we're afraid. So
so
that's kind of
true.
where I pivoted Cortex Gold, which Gold stands for Guiding Organizational Leadership to Deliver, to innovative solutions that would really help secure our workforce, whether that's safety and security from a physical security standpoint, psychological, emotional, but also what can we do to retain our staff? Because ultimately, no one's going to listen to anything that we put forward. And that's what I tell nurses all the time. If you want to create meaningful change at the bedside or in your profession, figure out how it's going to save something money, because
Right.
ultimately, healthcare is a business, and we don't want to talk about it. It's obviously, there's that debate between whether it's, something that's a human right or something that's a business. Well, we're not going to change that systemic outlook.
Until it's all about
And
money, right?
right, it's
How
about
can you save
budgeting.
them money? It's very true.
It's the way that our system is designed, unfortunately, might not be the best design. But while people like us are trying to look at it from a strategic approach, when I meet with organizations like the AHA or the Institute of Homeland or whoever, we're having those big, long conversations about what we can do. But in the individual aspect, when we look at trying to make an impact in the profession, really it's being professional by understanding the constraints with which you do your job. So yeah, care is an important portion, but also so is resources, and so is access, and so is all the other things that have to do with a profitability of a business, because the more profitable that they can be, the better you're going to be able to perform your job, because we're going to have more revenue to funnel towards that. And a good friend of mine, a consultant that I work with, Dean Malpass, who's like really well known in the UK industry for social care and mental health care design, says like profitability will always flow to quality, because you have to have quality in order to have a brand and a presence and all the things that these bigger organizations have developed. But because the healthcare system itself didn't change with the, inflation rates and the cost of medication and all this other stuff, it's created kind of a systems collapse. And one of the things that
Sure.
ultimately a downhill representation of that is the violence, because it's coming from frustration. So it's coming from fear. It's coming from a lack of trust. It's coming from, we had, depending on what your Facebook feed looked like, whether you believe vaccines were real. And now you've got
Right.
all these nurses that are, seen as, in some populations, as sheep, in other populations as heroes. So you kind of have to figure out who your demographic is. And one of the things that will save nurses is this ability to remain as a professional. And so professionalism training, is really important. And that's like what you and I were talking about with these influencers and LinkedIn people that just
Oh,
leave the bedside
yes.
completely. They just go completely, and they're like, oh, we're going to create bedside solutions, but we got to get you out of there. We can't let you work there anymore. Like, you got, it's
And
terrible.
that's not exactly the solution, because like we were talking about Lori Brown,
Mm-hmm.
and you listened to that episode with her, and we kind of talked about that a little bit. Like, one person's hell is another person's heaven in a workspace. you
Well,
know.
also, if we
Eh,
all leave that have the experience to deal with a cantankerous patient or to, to have, if we all leave, who are we leaving our stuff with if we
exactly.
don't teach them? And then one day we're all going to be patients and we're going to be like,
Exactly.
oh shit, like these people have to wipe my butt and they like, I don't even want them near me. Well, you were the portion of that left instead of saying, okay, I can keep one shift a month and sort of,
Exactly.
maintain some
Exactly.
unit. It's nice to go to work. I find that like when I'm there at that, shift that I can make or the commitment that I can maintain, lots of nurses are coming over to me. Hey Mel, oh my gosh, I had this last week. What do you think about this? Or, the technique that you taught me 2 weeks ago to deal with this patient. I haven't had a violent event yet. It's things
Wow.
like that where
Right.
we can test the content, but we're also
For
being able to
sure.
take that. And when I go sit in front of a boardroom, who in hospital structure, you've got like bedside staff and workforce, and then
Right.
you've got your executive team, and then you have your board, your advisory board. And a lot of times these executives make an effort to hide the issues that are in the organization
Sure. For
from the board,
sure.
right? But the
Sure.
board is the board for a reason. They're experienced business folks. They have a lot of network connections. So like if there's a problem that exists, usually the board could be able to help you figure it out, but you have to know how to analyze the problem and deal with it. And I think that's one of the things that I like to translate for the board, right? Is like,
Mm.
okay, this is the problem. This is why you're having this issue. Here are other problems that exist in your organization because we've done some surveying or focus groups. And then let's see how we can coach the executive team to make really smart decisions. And oh, by the way, last week we did it over here and it worked out well, or this organization looks like you and had similar results, or we're working in collaboration with the Institute of Homeland Security to study some stuff. You might want to try this for your organization. So it's a really neat place to be and be able to represent our voices from the bedside to that boardroom approach.
For sure, for sure. And I do the same thing. Like I work like 1 or 2 days a week in clinic. And it's kind of the same thing, I'm bringing a different perspective. I see like a whole different host of patients than the doctors see. Mostly the young teens, the kids that have questions about transgender issues and
Mm.
stuff
Oh
like
my
that,
gosh,
and
I would
sex
be so, we'll
issues.
have to talk about that offline, but I would be very interested to hear your experience with that. That's all I'll say about that.
Sure. Yeah, and that's a whole other topic, but I have been studying this whole trans issue from day one since about 2015 when Caitlyn Jenner came out, and I've studied it not only through a healthcare perspective but also through an art perspective, you
Huh.
know, and I've encountered many trans people, living in Los Angeles. For a period of my time, I had a lot of gay friends, and I hung out in West Hollywood. That's all I actually
Right, right.
did with
That's
my
like the
friends.
demographic. Yeah,
And it was a very interesting time. And you know, I am a straight woman, and it was interesting just to see. And there was no judgment at that time
so yeah,
about
as a
who you
nurse,
were.
that's really why I like to in the opportunities that I've been able to kind of talk and speak with politicians and work in a little bit of that bipartisan legislative approach is really because I believe as a nurse, we're going to take care of you no matter what your beliefs are.
Sure, of,
What,
of
we
course, of
we
course.
provide the same type of care because I'll tell you what, a really sick trauma patient that just got ejected from a vehicle, it doesn't matter what any of that kind of stuff, demographics, we're still going to treat you the same way, right? And I think like that really allows us to have a very unbiased approach and look at it from a perspective of true compassion and true empathy and care, but then allows us also to kind of help those organizations navigate through some of those difficult situations. Because like from a PR standpoint, a media standpoint, that's where a lot of decisions in healthcare is made, right? The largest budget that a healthcare organization has is its marketing budget.
For
And there's a
sure.
reason for that. There's a reason for that. And so like if you can figure out how to retain and recruit whatever initiative you're working for from an emotional or social perspective, um, you know, that's where it becomes beneficial to a hospital to care enough to create system change.
I love that. I love so many things that you said. I had Joey Ferry on, and he's the
Oh yeah, I love
Joey
Joey.
Ferry.
Yeah.
And one of the ways, because you brought up a great point, how can we save these hospitals money? And that'll open a door into an entrepreneurial venture. So with him, and you can go listen to that episode if you want on nursing innovation, he found out a way, like he did a research study for the hospital on linen costs and how
Yep.
much money they were spending on linen because they were using the linen to pad the
The
side
rails.
rails.
Mhm.
And so, and right there, he did a study for them and it really launched his
Yep.
career into
Yeah,
this whole entrepreneurial venture.
the research is important, and that's why we were really honored to be asked by the institute to do their some of their research and just help with other organizations like the International Association of Healthcare Safety and Security. They have a strong research connection. There's many opportunities to publish on something, and so those have been the opportunities where we've had to try to innovate to meet market need, to meet the need of our boards that we're consulting, and to answer some of those questions, because there just isn't enough evidence. There's not enough data in this space to give us any indications for true workplace violence prevention efforts. If we don't have a baseline data, how do we know we're doing well? Is there benchmarking opportunities? And then what are the things that we even want to benchmark to?
I love everything you're doing because, and I want to talk about how you got into workplace violence because it is kind of a new frontier. Like it's something that you always think about violence in the workplace. Oh, security, I'll just take care of it. But it's just gotten worse and worse and worse over the years. I mean, I
So
don't know one nurse who has not suffered something. Like
yeah,
I've been punched in the face.
our
I've been
surveys say like 98% of all healthcare workers have been a victim of violence, physical
right.
violence. And so the psychological portion, the threat of violence and the actual violence itself, there's really no delineation. In fact, the threat can be worse because our mind can run away with the thought of what they would actually do to us. But second to an underground mine, an ER is the most dangerous place to work in the world right now.
Wow.
So that tells you the type of violence that these organizations are facing. And, in the United States, we don't have strong legislation. And that's kind of the collaboration that I've been able to develop. So about 4 years ago, or 3 years ago, I was assaulted with a metal mop in an ER. So I
A
was the nursing
metal mop?
yeah, I was a
Oh,
nursing
wow.
supervisor of a small community ER in rural North Carolina. And I was weekend supervisor and also had two critical care patients up front that I was managing because we just didn't have experienced staff. It's like 30 patients, 40 patients, couple chest pains in the ED. Both the nurses on were less than 6 months of experience running charge.
Wow.
So I was down there helping, and they had all these psych patients holding in the back, and this one guy just really got escalated, got a hold of a mop, really, and as a result of me not being able to get past him, he was like 6'2", like
Oh my gosh.
250 pounds, big dude, non-compliant to pain because he's in psychosis. So I had a patient in the front room on vasopressors. He was not maxed out on epinephrine and his epi ran dry. And I couldn't change the bag. So we ended up arresting and dying. So he died as a result of that patient causing violence in the ER. And I kind of looked around. I was like, by the time the cops got there, it was 15 minutes. They didn't get the message it was a weapon. So they had been there all day with the guy using pain compliance techniques. And so I became, as the nursing supervisor, the target of their pain compliance techniques because I
Wow.
let them do that to him while he was in the hospital. So after that, I was like, this really shouldn't happen anymore. And I went on this like crusade of just meeting and learning from the top violence experts in the world. I didn't care what industry. I've talked to, special forces guys. I've talked to, executive protection. I went out and trained with Covered Six, and we had my co-founder went out and trained with them for months and learned how to be a level 4, covert officer. And, we trained with the best healthcare security folks, the best mental health resources from the UK. And so now the UK has some higher standards than what we have for us currently, and some of our legislation is shifting that way. So we're able to see the things that they did really well over there and the things they didn't do so well. So that's where we've created this network of collaborators that consult for us and with us for these organizations to create really innovative solutions and then do the research behind it.
So fascinating. I mean, I had a nurse on who was assaulted by a doctor.
Yep.
I mean, she was in the post-op, and I think she was a charge nurse, and this anesthesiologist was turning off the monitors, the beeping monitors, and she told him, like she had told him before, and she noticed that this was a habit with him, and she went up to him and she's like, "Hey, I told you, to stop doing that." And he just went and started choking her. And her medical director was like, "Oh, he said he'll never do it again." Because
Did
he
you hear
barely
about that
let go.
hospital? I think it was I don't want to say who it was because I don't know specifically, but there was a story that was just recently released. And then there was like a TikTok video from one of the nurses
Uh-huh.
where the doctor had threatened to like literally bring a bomb and kill people and
Oh
blah,
my
blah, blah,
god.
and like direct threats and had been like very violent to the staff. And they let him come back after he
Oh
went
my
to
god,
jail. And he was
no,
arrested. He
no,
was
no.
arrested, posted bond, and then he came back
Yeah,
to do his surgeries. I was like, what?
no,
Like,
that is
and the hospital
crazy.
let it happen. I
No,
was like, and nothing happened. Like, oh, don't do that again, hospital. What the actual, I just can't. And like in the UK,
yeah.
places like that, that would never happen. Like they
Yeah, it
would
happens
never.
here so much. I mean, there was also Doctor Death, that whole podcast and show. Now I think it's like a series.
Mhm. Yep.
And the guy did the same thing, and we also I had Charles Graber on the show, The Good Nurse, same thing.
Yep.
That guy in 9 years, like, worked at tons of hospitals, killed tons of people. I even worked with the serial killer. He was a respiratory therapist, and I was like, this guy is acting weird. And I was a new grad. Why do we have so many code blues? This guy is acting weird. Oh, he's so nice. Well, he killed like 50 people at 2 hospitals. And not only that, he was creating copycats. Okay. So the other respiratory therapists were doing the same thing, offing people to lessen their load. This is where we're going,
It's
and
and you
I'm
know
just
what it is,
like,
and it really is
hello.
because there's so many system stressors that no one's really addressing because I think it's that they just don't know what to do. And it's because you've got such a division between academia, administration, and the bedside that there's not enough collaboration there because there's been that
Sure.
middle channel of like middle managers and experienced nurses that used to advocate. We always had to advocate for a profession. Like, I
Right.
don't know where you guys
Always.
forgot the idea of like Nurse Ratchet, and these like nurses eat their young. They weren't only eating their young, but they were eating administration too for us. They
Sure.
were down there
Sure.
knocking on the door, like, hello, like, we need it. We've always had that position. It's just that now I think in the younger generations, they are not used to having to advocate. And when they try to advocate, it's through this like negative, like TikTok, social media, like this environment,
Yeah.
like pure negativity. Don't be a nurse, be a realtor. Like, and it's like, okay, well, we did, and we're here now, and we have to do something to save our profession. So what's the thing
Exactly.
that you can do? Like, you write, you do podcasts, you continue to work at the bedside when you can, and give your skill set. Like, we're in a staffing crisis, so I don't have to work at the bedside anymore, ever, if I never wanted to again.
Exactly.
But I
Exactly.
do because I believe that the time that I'm there is valuable and can be helpful. And I'm good about keeping my
Sure.
fucking mouth shut about, what's going on. It's like how can I be a
Sure.
positive representation for what's happening and to coach and be a positive example when I'm
Yeah.
there?
And these influencers, and that one particular that you posted, we won't say who it is. You posted on your LinkedIn. I was following her from the
And
beginning
I
because
had no idea who she really was. I
yeah,
just happened to see it on my feed and I was like, oh,
yeah, I
this
was
is part of
following
the
her.
problem.
Yeah, I was following her in the beginning because she was covering a trial, which people paid her. So nurses sent her money
Wow.
for her to go fly out, get a hotel, and go to this trial for 3 days. Right. I was like,
Wow.
Lord, that's what she said. That's her story. Who knows if it's true? So I started following her because of the trial and I liked her commentary, but then she started getting very, very negative. And I was just like, no, if you understand what's going on with the trial, and I talked about this with Lori Brown, it seemed a little bit shady, like this nurse was set up, and it was like an administrative flaw. Sure, she made an error that killed someone, but still, you know,
Yeah.
the way it was handled was terrible. Anyway, and then I just started noticing how negative she was and how nasty she was. She
And I
wasn't
think
giving
it's not just
anybody.
one person in particular. I think
No,
it's like
it's a
a
lot.
culture. It's a culture of like nurses who are negative, and then when they get to the bedside, they're negative there,
Yeah, yeah,
negative with each other, and they're rolling their eyes during report, and they're just like, and it's just this angsty approach. And I'm like, okay, like, and
that's
when
not what it's
and
supposed to be
and when
about.
yeah,
I
and when we're
mean,
precepting, I remember when you used to get like when you were precepted to a new job, there was a time where your preceptor would be like, "Hey, we're gonna talk about the things that you didn't do great this week.
right,
Like,
right, for
there's
sure.
something," and it was awkward. It was really awkward for a
Well,
minute. You were
well,
like,
of
"Oh,
course,
mommy, I'm sorry." They don't do that now. It's like they run to the nurse manager and say they're just really not prioritizing their tasks. So then the new nurse gets pulled into and they're like, "I had
Oh,
no
I
idea.
know, that's
Nobody
even
said
worse.
anything to
Right,
me." And they're all talking about each other. And it's just that's the professionalism element that
yeah,
part of workplace violence prevention. Because if we are a cohesive unit, right? If we walk into the room, and even if Joe Blow over here is transient, right? He's homeless, he's got some mental health issues, he may have a substance abuse. If we're
sure,
together and cohesive and we act like we're a team and we've got each other's backs, people aren't going to mess with us. Like there's just a
right,
cohesiveness about the teamwork that exists when you do that. And that's one of the things that I've, noticed from facilities that do this well as far as workplace violence prevention and unit cohesiveness. Those two things go together. And guess what? People want to pick up shifts there. People want to work together there
right,
because they help each other.
exactly. And that's like so huge. I mean, I've even been as a patient seeing like a nurse practitioner in certain areas, like they were not very nice to me. Even going to see a doctor, and I was like, and I try to like change up. I was like, okay, maybe I'll go in the morning because this person will be spry and cool. But so much just negativity and being nasty. And even I've worked at a few federally qualified clinics in, lower socioeconomic areas, which I do enjoy working at because
Yeah.
I find it very, very interesting. And but these doctors are like, "Oh, I'm just here to pay off my loans. And they're not very nice to the patients. And
There
and,
is,
and,
what
and
happened was COVID hit, and all of the nurses that were trained during COVID did not learn any empathy because
well, I know that's been going on for a long
we weren't
time, Mel,
giving
though. Even
I think so.
before, even before. Yeah, I've seen
I
some.
saw a major shift, at least in the ICUs, because before it would be like at least the nurse would go in and like wash their hair, or
Oh,
like
yeah,
try
I
to
used
get
to
them
always
by
bathe and give
that doesn't exist
massages.
after COVID
Yeah.
anymore. Like those nurses, there have been tons of patients that have never had a soap and water bath because
Wow.
they never knew that during like before COVID, we used to like wash people's hair when they were
Yeah,
intubated.
yeah, for
Like they're
sure.
like, why would you spend the time in there to do that? I'm like, that's literally that's
That's
the
your
whole
job.
point. Like that's why we're
Yeah,
here. Like Epic and tasks lists and like making sure they live is like an added benefit of being a
yeah,
nurse. And like that's the portion that's missing. Because I can go into a room and with 20 seconds develop rapport with somebody because I know
sure.
what to say and how to do it and how to make eye contact because I've been doing it for so long. And I know that if I spend that first 15 seconds getting to know you chit chatty, then the part where you're frustrated with me because the doctor didn't do something that they wanted done in a timely manner, I'm not gonna be a target.
Sure. I read an article, and this was before COVID, because I was like, oh, storytelling would be great here. And a lot of these new nurses were like, my patient wants to talk to me forever. I mean, they didn't even know, they didn't understand that connecting with your patient and developing a rapport is so important. That's part of your job. I mean, I had a class in nursing school 100 years ago, and it was about active listening.
Right?
You know, you're there to just listen, and that is part of your job, and they're just like, "Oh,
And
I don't
that's
have
why
time
I
for
think
them."
time and
It's not
billing,
just tasks,
right,
you know?
time and billing is really got to be updated with nursing because no one takes into account the time that it takes to be present with a patient. And that's really one of the key things about when we come in as consultants and do surveys is that if we don't have enough time and we can tie the time to retention and to metrics and feasible profitability scales, then we can prove that we should have a better staffing model. Going in and just saying like we have too many patients doesn't make sense to anybody
Yeah,
from
yeah,
a
and
and
this is
so
what we're hearing. This is the narrative. Staffing, not enough patients, nursing ratios. You know, there was one nurse I saw on TikTok. She's like, "Oh, I went in there and they had 8 patients for me, and I just walked out, and they called me the BRN on me because she like abandoned her patients." I was
yep,
like, "Girl, you understand where you're going. You know how this place works. Call them before your
right,
shift and say, how many patients am I going to have? Who's going to be there? Or when you're there, go, okay, I need some resources. Who's available? Call the staffing office, you
yep.
know,
Or call
make
Safe
yourself
Harbor.
a leader.
Do
It's
yeah,
just like you
do
don't just walk out. Like, what if you were a patient there and you heard this nurse just walked out? You know? I mean, I walked out of my clinic the other day, but it was because I had specifically said certain things needed to be done because I had an issue with someone who I was working with, and I go, "I cannot work with this person anymore. She's unsafe." And I had
uh-huh.
written many emails to my medical director
Because
to
it
do
causes
that.
liability on you because you know.
Exactly. It was very, very scary. This person just shifted, and I'd known her for a very long time. And I just was like, can't do this anymore. You know, I cannot baby her and coddle her. I'm scared now. You know, what's going to happen? And so, when I went to work one day, she was there and I left and I called the guy and I was like, "Hey, we talked about this." And he's like, "Oh, she's not supposed to be there." You know? And I waited until she left. I go, "I hope she understands that now she is creating a patient issue." Because it was
Yeah.
all because she thought that it was okay and it wasn't a big deal. And I was like, no, she did massive stuff wrong. And it wasn't just a 1 day thing. I started to put this all
And I
together and
think
what was going on.
that's where we need to be like using our administrative resources, right? It's not for the lateral violence and the bullying that's going on, like
Right.
where somebody makes you upset and hurts your feelings, so now you're reporting them to the
Yeah,
board.
that's not what it was about. No.
Like, no, it's like if it's a care issue, if it's an
Yeah,
actual issue, like that's when we go to management. Other than that, you're dealing with things interpersonally, professionally, and that just doesn't exist anymore in our profession. And that's something
sure.
that, when we go out and train and when I go out and speak to people, that's one of the things that I try to do. And that's something that I cover in that book that I'm going to be putting out
That's
because,
awesome. And we'll talk about your book.
yeah,
What
yeah,
one of the things, like, I remember working at a federally qualified clinic, and a couple of them this happened to. And one of the things with these federally qualified clinics is they have administrative staff who don't have a healthcare background. Maybe this is their first job in healthcare, so they don't understand situations. Like,
right.
one time I had a patient, the mom was being very violent, and
Mhm.
she was being weird. And I said, well, I don't have to see
Yeah,
this
pediatrics
patient,
is a pretty dangerous place because of the emotions.
Sure, sure. And I go, there was something going on where this mom didn't have custody of this kid, but the grandma did. And the grandma was waiting in the waiting room. I was like, no, 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 no. I need to be in the room with the person who has custody, not the person who doesn't. And this mom started to get violent. So I refused to see her. Well,
Yeah.
the administrative secretary came in and she was sleeping with the medical director, and she thought she could tell me what to do. And she threatened me. She's like, either you see this patient or you don't work anymore here. And I was on a locums assignment. So I was just like, are you kidding me? You know? And so
Yeah,
she goes,
you're
well,
like,
I'll
no.
come in with you. Well, now you're just a secretary per HIPAA. And if you go and look at what the
Yeah, she
BRN says
doesn't
in
have
California,
critical. She
you
doesn't
do
need.
not, you can't be there.
Yeah. Yeah.
You cannot be in the room. Like she didn't even know that. That's how dumb she was. Another situation, I was working at another federally qualified clinic, and the manager worked at Subway before, right? So I had, you know, something happened and it was a foster mom and she started screaming at me. And it looked like, and she lunged at me and I lunged away and I walked out of the room and I said, I can't take care of you anymore. And I went to go tell him and he's all like, oh, you just have to grow a thick skin. You have to deal with it.
Technically, per your Nursing Practice Act, and every nurse that's listening here, if you are not mentally, physically, or emotionally capable of caring for a patient and you assume care for them, that can be considered malpractice.
Right.
And if you have 5 other patients you're responsible for direct care, and you are hurt because of one patient, you're now responsible for the other 5. So this is why I tell people, like, make sure you read your state practice acts, make sure you know
Exactly. It's
your
so
rules,
important.
and now Texas legislation in SB 240 is supporting the idea that it is written into civil law now that as of September, I think they have to have everything in compliant by September 1st, that you have the option to have your assignment changed if
Oh,
you've
for
been
sure.
threatened
Sure.
or assaulted by a patient. But we don't have the staff to do that. So I don't know who wrote that or where they got that from, but okay.
Yeah.
Well, I have found a technology solution that'll help with it though. So it's good. I'm like finding, that's what I like to do, right? Is like, what is the complicated issue that nobody's talked about how to fix? And then let me find somebody who can fix it.
Yeah. Your brain is so like mine. So tell us about your book. And
So
it's perfect for Nurses Week that
yeah,
you're
so
rolling it out.
as much as I really like talking to organizations and big, and boards and consulting, obviously a lot of my knowledge is actual bedside application and what can we do to protect ourselves and our patients and each other while we're at the bedside. So I decided to do a clinical safety guide, and it really is just a handbook on what to do, what to look for, foundations of security, so you can even have a conversation with your security director about things in an intelligent way. They speak a different language, right? And a lot of the problems that I've seen with training that is developed for workplace violence prevention is that they're policing based, right? So as a
Mhm.
police officer, they have a badge, they have a gun, they have a different use of force continuum. They can actually put people in restraints or handcuffs. We can't do any of that kind of stuff, right? So our approach has to be much different. Plus, we're 80-90% female. So we need to have a completely different approach when we are looking at dealing with violence, and that is by having a high degree of soft skills. So some of the things in the book that I cover are like scene safety, like how to go into a scene and what to look for as part of your assessment, and how to tie that into your nursing assessment. How do you document when a patient, and what do you document? What is a behavioral anomaly? What do they look like? What are indicators for violence? One of the things I say all the time is if a person is rolling their eyes at you, that is a behavioral anomaly. Unless I'm a 14-year-old girl and you just told me I couldn't go to prom. Like that is something that is a behavioral anomaly that is very often overlooked. If you are seen as an authority figure, someone should not be rolling their eyes at you. If they are rolling their eyes at you, that should count as number one. Then if you say, Mr. Jones, can you please tell me your date of birth? And they won't take the blanket over their head, you shouldn't walk over and just take the blanket down.
Oh yeah. Yeah, for
Start
sure.
at the feet, maybe lift up, ask permission if they're not going to participate, and then you document it. You document, I observed 3 behavioral anomalies indicative of violence, or this patient has showed active or passive signs of violence. They're hitting, spitting, kicking. I will provide life-saving care only, especially if your policy and procedures and you don't have the right amount of resources in that organization. If you
Right.
can't call security or get on the phone with a doctor or get what you need to take care of this patient appropriately and safely for yourself, then you should really consider having a conversation with your organization about the policies and procedures that support you and being able to write a note that states will provide life-saving care only. Because guess what? When they're coding, no one's
Oh
going to hit.
yeah. Oh, for sure. For sure. I love it. So do you also work with police departments?
I
Like we kind
do.
of
I
talked
do.
about that study that's going on. I believe it's in Toronto, Canada, where they're sending out psych nurses with the police officers to deal with the homeless population.
Yeah,
So
so mental health response is like a major part of this, right? Because when we're looking at gaps that whether it's the transient population and how are they cyclically returned to the streets without the resources that they need, or are we talking about mental undiagnosed mental health? Are we talking about behavioral health within school systems? But really the community is where we find these folks, right? So when I was looking at a way to help offload the burden into the healthcare organizations, I started looking at people in the UK because they have a better model for how they deal with these things because their
right,
system's just different. So I actually networked with Dean Malpass, and so he's an advisor there, and we came up with a model. And he's putting out a book and a model that make safe, make sense, make right. And it is a model that's designed for police officers and first responders to be able to identify mental health crisis in the field and then appropriately deal with it in their scope.
right.
So now we have the scope creep, right? So when that happens, it's like where things move into another zone where they're really not capable of taking care of things. And that's what happened in that event with me and the psych patient and the metal mop is nobody
Mhm.
knew their roles and responsibilities. We didn't have the right policy and procedure, didn't have the right training, didn't have the right support. So it's a breakdown of that whole system. But that system starts with the police that picked up this guy on the street for, unusual behavior and was brought in and dropped off. So how do we empower those folks to cops to stay out of court? Because ultimately, though, if he would have had a weapon or a gun, their goal is to neutralize that threat. And there have been many opportunities where officers, because of their mental health training and because of the litigation issues, they haven't neutralized the threat and someone's gotten hurt because they
Mhm.
realize that they're a psych patient. So I think there's an opportunity there to be able to look at a very good comprehensive response because the solution is not cost effective to take a nurse practitioner or a psych doctor and have them work as a beat cop. That's not the best way for that to go down. They have to have
Mhm.
assessment criteria, they have to have
Right,
length of time to treat the patient. Like that's not a comprehensive solution to this. It's a band-aid and it's an expensive one that
right.
we recommend, right? So how can we look for something where the cops can be cops, but also allow us to get the data that we need to make an
Mhm.
informed decision before they even get to the ER? And can we standardize some of the verbiage with our training? So, like, for instance, we're offering like mental health response workshops. So, an
I love that.
organization like a police department, because they're struggling to make money too, right? So, they can book us and then sell tickets for as many tickets as they want, and they can make revenue off of us coming to deliver this program. And then in September, we're having our first innovation and safety symposium, which is going to be focused on that mental health response unit, and the recommendations. I'm going to the UK in June to study with some clients and look at their models and look at their policies and how they do things from a legislative approach all the way down to the actual bedside response, and then try and come up with some really good systems, parallels. And we're using the Institute of Homeland Security. We've been endorsed by law enforcement today for our police approach. We have a DDT model, and I think Dean has a book that's coming out soon on that too. So it's kind of neat because if we can get the verbiage together for them and then get the verbiage together for the nurses, then we can kind of collaborate and exchange information, and we can be able to push that data back to big organizations that are trying to give proof of help, right? If we have the data there that says there's this high volume of people that need a place to go and we need resources, then we can apply for federal grants and legislation to be able to provide those things.
I love that. I mean, here in Palm Springs, we're seeing more of a growing homeless issue, just like Los Angeles. Los Angeles is
It's
absolutely
bad
out
here
of
in
control.
Austin. It's really
Yeah.
bad in Austin too.
So they had this police chief that they hired a couple of years ago. And so he was in Santa Cruz and then he was in Eureka as a police chief. And I did a deep dive on him because he's not a very nice guy. I mean, I had written the the mayor lives in my neighborhood, so I wrote her some emails about certain situations going on because of Coachella and because of the festivals that come into town. We get a lot of traffic.
Mhm.
So I started noticing that police officers are heavy for certain things
Mhm.
and not so heavy for other things that really just involve the citizens who live here full time.
Yeah.
Because there's a lot of people that come here recreationally and stuff. But I did a deep dive on him because I kept seeing, they kept putting in so much money into the homeless population and homeless issue, and they built a shelter and stuff. But we have people just slaying out on the sidewalks and
Mhm.
just uncovered, just passed out in the bus stops and stuff. And it's like, with him, he keeps saying the same thing. There's nothing we could do. There's nothing we could do. There's nothing we could do. And I was just like, no, that's not true.
And I think it is like it's a funnel, right? Like it's just
Yeah,
like lead generation in the business, right? There's business out here. We know that it's there, but how do we get it concentrated? And I think one of the
sure.
first steps is looking at dispatch calls and looking at the calls that are coming in and figuring out, classifying them, being able to look at trends. We can leverage
Right.
technology, AI now, and do predictive analytics. So like to say that there's nothing that can be done is really naive now,
Yeah, yeah,
because so maybe we need to just be more creative in our approach. But I think ultimately, once we can get these people into the funnel and into resources where they can get help, then we can do that. But ultimately, we can't fix social construct problems and big large that takes a tremendous amount of funding and government support. But what I can
sure.
do for officers and for sergeants and captains that are have that same approach, is to give them really great training to at least ensure that their cops can avoid liability when they can stay taking care of the things that they should be taking care of, and then passing it off. And in the UK, the police chiefs and the nursing organizations came together and wrote the letters to get the changes done from their government over there, because they came together as a combined unit saying our departments are stressed, their inpatient departments are stressed, you guys need
Right.
to come up with the funding to do something about this social problem that we have created because of inflation and all of the other reasons why people are substance abuse and opioids and all the other reasons why everyone's unable to function like a person that doesn't end up on the street.
For sure. So
So
what's in the future for you then? You have your book.
yes.
You have
Right now, just trying to get in front of as many boards as we can to make impactful change, each organization at a time, no matter how small, how big, has opportunity for improvement and to be a part of this. And then, on a really global scale is creating that. We're writing the first textbook for workplace
Oh, I
violence.
love it.
Yeah, so we've come together with a whole bunch of advisors across the world, and we'll be starting production on that. And that'll be available to university students as well as, future medical directors, future, administrative people. But there'll be something in that textbook for everybody, to be able to understand the climate of healthcare violence. We'll have case studies, we'll have recent research, and then obviously just growing we have a podcast too called Tactical Scrubs where we share a lot of information.
Awesome.
So, just growing that brand and being an available resource to nurses and doctors and healthcare workers, and teachers in the school sector.
I love it. So where can people find you, Mel?
They can visit our website at cortexgold.com, or I'm pretty active on LinkedIn. Make sure you follow me on LinkedIn, and we're here to help. I tell people all the time that my clients are anyone who cares.
And you're offering your book for $5.
$5. Yep, it's $5. It'll be available on sale next week for Nurses Week. And we have lots of other resources in our library like that make sense, make safe, make right. And then Dean is writing this really cool mental health workbook, and it's like got each page has like a different diagnoses,
Oh,
and then
awesome.
symptoms, recommended medication treatments, like recommended therapies, like all in one page. And then it has like his top 5 triggers so that you can reduce, you know, violence. It's pretty cool. It's a really neat.
Awesome.
We just did I just looked at panic disorder the other day and I was like, that's like every homeless person I've ever taken
Yeah.
care of.
Yeah. Wow. Awesome. This has been an amazing conversation. I learned so much. I love it. Thank you
Thank
for
you.
being on, Mel.
I really appreciate it. What you're doing is awesome. And,
Thank
keep
you.
writing, keep
Same to
making a
you.
difference.
Cool. Thank you so much.